Hey everyone, my name is Christina and this video is on vitamin B1. So imagine you're on your emergency medicine rotation. A well-known patient and alcoholic stumbles into the emergency department and is lethargic and dazed. A quick finger prick reveals he's severely hypoglycemic. A nurse then proceeds to give him dextrose or glucose in order to bring his sugar up, but before she could do so, the attending in charge stops her. Why did the doctor stop her? What step was she missing? Administration of vitamin B1 or thiamine is needed first in order to prevent Wernicke's encephalopathy, a life-threatening condition you will learn about shortly. Today you're going to learn all about vitamin B1, aka thiamine. This vitamin is very important because a deficiency causes several different clinical conditions, all super important for your Step 1 exam. In the next few minutes, you should be able to 1. Identify the function of thiamine and thiamine pyrophosphate, 2. Recognize the clinical significance if a patient is deficient, and 3. Understand diagnosis and treatment modalities. Vitamin B1, or thiamine, is a water-soluble vitamin that's found in grains, meats, and legumes. B1 functions as a cofactor for several enzymes in the form of thiamine pyrophosphate, or TPP. TPP is formed from thiamine through ATP donating 2 of its phosphates, which are these phosphates here. It's very easy to get thiamine and thiamine confused simply based on the spelling and pronunciation. Thiamine is a pyrimidine nucleobase and one of 4 nucleobases in the nucleic acid of DNA. Remember, GCAT. For more on thiamine, check out our video of nucleotides. Lastly, don't get thiamine confused with thyme either, an herb used in cooking. Okay, so back to thiamine and TPP. TPP is a cofactor for many dehydrogenase enzyme reactions. Do you remember what dehydrogenase enzymes do? They catalyze oxygenation reduction reactions. The 4 dehydrogenase enzymes are branched-chain ketoacid dehydrogenase, alpha-ketoglutarate dehydrogenase, pyruvate dehydrogenase, and transketolase. Branched-chain ketoacid dehydrogenase is needed to degrade branched amino acids such as isoleucine, leucine, and valine. A deficiency in this enzyme causes maple syrup disease, an autosomal recessive condition that results in vomiting, poor feeding, and urine that smells like maple syrup or burnt sugar. For more on maple syrup disease, check our video on the topic. Now the remaining 3 dehydrogenase enzymes are all involved in the TCA cycle or glycolysis. Alpha-ketoglutarate dehydrogenase and pyruvate dehydrogenase are both directly involved in the TCA cycle here. Pyruvate dehydrogenase metabolizes pyruvate to acetyl-CoA and links glycolysis to the TCA cycle. Alpha-ketoglutarate dehydrogenase metabolizes alpha-ketoglutarate to succinyl-CoA and allows the TCA cycle to move forward. Now, transketolase is involved with glycolysis through the H&P shunt or the pentose phosphate pathway. If you recall, the H&P shunt provides a source of NADPH from readily available glucose-6-phosphate. NADPH is needed for several reductive reactions. Transketolase metabolizes ribose 5-phosphate to fructose phosphate or other glycolytic intermediates. From here, breakdown of glucose can occur through glycolysis, or the formation of glucose can occur through gluconeogenesis. Okay, so we just went over the function of thiamine through TPP. As you just saw, TPP is an important cofactor for so many different reactions. So what happens when there is a deficiency in thiamine and therefore a lack of TPP? When B1 is deficient, these enzymes can't function. Glycolysis in the TCA cycle partially shut down, and this results in reduced production of ATP. Now, how does this manifest clinically? Well, one way is in Wernicke's encephalopathy, an acute life-threatening neurological condition. It's especially worrisome in alcoholics or malnourished individuals that are prone to thiamine deficiency and hypoglycemia. Giving these patients glucose in the form of dextrose infusions can precipitate Wernicke's encephalopathy since a breakdown of glucose is already impaired. As in our example from the beginning of the video, thiamine should be given to anyone suspected to be deficient in thiamine prior to giving glucose. Wernicke's encephalopathy results in a triad of confusion, ataxia, and ophthalmoplegia, which is paralysis or weakness of the eye muscles. Korsakoff syndrome is another clinical manifestation of thiamine deficiency. Korsakoff syndrome is an amnestic disorder due to alcohol consumption. This results in confabulation, personality changes, and potentially permanent memory loss. Not to get confused with Wernicke's encephalopathies or Korsakoff syndrome, is Wernicke-Korsakoff syndrome. This results from damage to the medial-dorsal nucleus of the thalamus and mammillary bodies. As the name implies, it consists of a combination of features from both Wernicke's encephalopathy and Korsakoff syndrome, including confabulation, personality changes, memory loss, confusion, ataxia, and ophthalmoplegia, as well as dilated cardiomyopathy. Thiamine deficiency can also cause severe and chronic conditions known as dry and wet beriberi. Dry beriberi causes polyneuropathy, including foot and wrist drop and symmetric muscle wasting. Wet beriberi causes high output cardiac failure or dilated cardiomyopathy, which consists of fast heart rate, shortness of breath, and leg swelling. Here is an image of an individual with beriberi. You can see the use of crutches is likely due to foot drop. Diagnosis is made through blood testing. High red blood cell transketolase activity will be seen following vitamin B1 administration. This test is also known as the erythrocyte transketolase activation assay. Treatment is done with thiamine supplementation, and this can be done both intravenously or orally. Alright, let's do a quick flash quiz before we end this video. Why should thiamine be administered before glucose in hypoglycemic alcoholics or malnourished individuals? This is because in alcoholics or malnourished individuals, the likelihood of thiamine deficiency is high. This means glucose breakdown is already impaired, and administration of glucose will further worsen ATP depletion. The risk of developing Wernicke's encephalopathy is decreased with thiamine administration. And recall, clinical features include a triad of confusion, ataxia, and ophthalmoplegia. Alright, so the bottom line is vitamin B1 or thiamine is a water-soluble vitamin found in grains, meats, and legumes. B1 function as a cofactor for several dehydrogenase enzymes in the form of thiamine pyrophosphate or TPP. These dehydrogenase enzymes play an essential role in the TCA cycle, glycolysis, and the pentose phosphate pathway, or HMP shunt. Deficiency in thiamine results in numerous conditions including Wernicke's encephalopathy, Korsakoff syndrome, Wernicke's-Korsakoff, and beriberi. And lastly, treatment is generally done with thiamine supplementation. Thank you for watching the video. If you enjoyed it, don't forget to give a thumbs up.
Vitamin B2, or riboflavin, is often found in dairy products and is a cofactor in many oxidation and reduction reactions. Most importantly, it's a precursor to both the FAD and FMN molecules, and in this form it can add or remove 2 electrons at a time from other molecules in a redox reaction. This is how it's involved in fatty acid oxidation, amino acid oxidation, and aerobic metabolism. It's also a cofactor for erythrocyte glutathione reductase and for the conversion of tryptophan to niacin, which is vitamin B3. Do you remember what glutathione reductase does? It reduces GSSG, which is the oxidized form of glutathione, to the reduced sulfhydryl form, which is an important antioxidant. Since erythrocytes are very sensitive to oxidative damage, patients who can't reduce glutathione due to vitamin B2 deficiency can get anemia. Deficiency in vitamin B2 can also cause the 2 C's, which are chelosis and corneal vascularization. Chelosis is inflammation of the lips, with scaling and fissures at the corners of the mouth, as you can see here. Alright, time for another flash quiz. So what are 2 symptoms of vitamin B2 deficiency? Remember, the 2 C's of B2 deficiency are chelosis, which is scaling around the lips, and corneal vascularization.
Hey everyone, my name is Christina and this video is on vitamin B3. Picture yourself on your internal medicine rotation. You see a patient with constant diarrhea a peculiar rash on his hands and around his neck, and a history of forgetfulness during the last few months. He also complains about a swollen tongue. What vitamin deficiency comes to mind, and how do you treat this? We'll be going over everything you need to know about vitamin B3, or niacin. In the next few minutes, you should be able to 1. Recognize the functions of vitamin B3, 2. Identify niacin deficiency as well as excess, 3. Understand the clinical significance of vitamin B3, and 4. Describe how to treat vitamin B3 deficiency. Vitamin B3, also known as niacin or nicotinic acid, is a water-soluble vitamin found in liver, milk, and grains. It is important to note that niacin is not found in corn, so individuals or cultures that eat heavily corn-based diets are at risk for niacin deficiency. Niacin can also be derived from tryptophan, with the help of vitamin B2, riboflavin, and vitamin B6, peroxidine. It is required for the synthesis of NAD+ and NADP+, which are both involved in redox reactions. NADH is required for electron transport. If you recall, the electron transport chain located in the mitochondria produces an electrochemical proton gradient that drives the synthesis of 3 ATP molecules. You can remember the number 3 because niacin is vitamin B3. For more information on the subject, check out our video on electron transport chain and oxidative phosphorylation. Also recall, NAD+ is needed for dehydrogenase enzymes. So what happens when you don't get enough niacin in your body? As mentioned earlier, niacin deficiency can occur if you eat heavy corn-based diet, which occurs in rural South America where maize is a staple food. If you don't get enough niacin through diet alone, you can also be at risk for deficiency. Deficiency causes nonspecific symptoms of dermatitis, glossitis, and diarrhea. Niacin deficiency can also be caused by Hartnup disease, malignant carcinoid syndrome, and isonazid use. Hartnup disease is an autosomal recessive disease due to deficiency of neutral amino acid transporters in the proximal renal tubular cells and on enterocytes. Tryptophan is a neutral amino acid. A lack in these transporters produce neutral amino aciduria and decreased absorption from the gut, aka decreased tryptophan absorption from the gut. Remember, tryptophan can be converted to niacin, therefore a deficiency in tryptophan means a deficiency in niacin production. Clinically, this results in pellagra-like symptoms. Pellagra consists of the 3 Ds: diarrhea, dementia, and dermatitis. The rash classically presents in a C3-C4 dermatome pattern and resembles a broad collar rash, which you can see more distinctively in this image here. Patients can also experience hallucination and hyperpigmentation of sun-exposed limbs, such as the hands and arms. Treatment is with a high-protein diet and administration of niacin. Malignant carcinoid syndrome can also cause niacin deficiency. Carcinoid syndrome consists of neuroendocrine tumors that release high levels of serotonin. Now, while tryptophan can be converted to niacin, it can also be converted to serotonin. However, in carcinoid syndrome, instead of producing appropriate levels of both niacin and serotonin, tryptophan is heavily diverted towards production of serotonin, and niacin therefore becomes deficient. In addition to pellagra-like symptoms, you can also see cutaneous flushing, wheezing, right-sided valvular heart disease, such as tricuspid regurgitation, pulmonic stenosis, nausea, vomiting, hepatomegaly, and pelvic fibrosis. Check out our endocrine video for more on carcinoid syndrome. Isoniazid use, or INH, can also cause niacin deficiency. Do you recall what disease INH is used to treat? That's right, INH is an antibiotic used to treat tuberculosis. The CT scans you see here depict multiple cavitary lesions in both the upper lobes and apical segments of the lower lobes, as seen in pulmonary tuberculosis. So what causes an excess of niacin? You're probably never seen this in someone who eats too much liver or drinks too much milk, but it can happen in patients who are prescribed large doses of niacin. Niacin can be given pharmacologically for the treatment of hyperlipidemia since it lowers LDL levels and raises HDL levels. While it sounds like this would be a pretty useful drug, it's actually rarely used because of the excess niacin risk. Since you have to give so much niacin to see the effects, you can get some pretty unpleasant side effects that include facial flushing, pruritus, hives, nausea, vomiting, hyperglycemia, and hyperuricemia, which can lead to gout. If niacin is absolutely needed to be given as a medication, these side effects can be reduced with aspirin use. Aspirin works by inhibiting prostaglandin production, the cause of excess niacin and facial flushing, not histamine. Alright, let's do a quick flash quiz. How does Hartnup disease cause niacin deficiency? Recall that Hartnup's disease is an autosomal recessive disease due to a deficiency in neutral amino acid transporters in proximal renal tubular cells and on enterocytes, such as tryptophan. A lack in these transporters results in decreased absorption of tryptophan from the gut. Because tryptophan can be converted to niacin, a deficiency in tryptophan means a deficiency in niacin production. Okay, so the bottom line: 1. Vitamin B3, or niacin, is a water-soluble vitamin found in liver, milk, and grains. 2. It can also be synthesized by tryptophan. 3. It is required for the synthesis of NAD+ and NADP+. 4. Deficiency in niacin causes pellagra-like symptoms and can be seen in Hartnup's disease, malignant carcinoid syndrome, and INH use. And lastly, 5. Niacin excess causes flushing as well as nausea, vomiting, hyperglycemia, and gout, and it is due to the pharmacological use in treatment of hyperlipidemia. Thanks for watching. If you enjoyed the video, don't forget to give it a thumbs up.
Vitamin B5, or pantothenate, is used to make coenzyme A, which is a cofactor for a lot of the metabolic reactions that we'll cover in the next section. At the end of glycolysis, pyruvate dehydrogenase can make acetyl coenzyme A from pyruvate and coenzyme A. As you can see, this is necessary for the TCA cycle, fatty acid synthesis, and cholesterol and ketone body synthesis. B5 deficiency is pretty rare, but it can cause dermatitis, enteritis, alopecia, and adrenal insufficiency. Alright, so we're going to have lots of vitamins and symptoms to cover, so I'll keep the quizzes coming. A deficiency in which vitamin causes adrenal insufficiency? So that would be vitamin B5, which you need to make coenzyme A. Vitamin B6, or pyridoxine, is found in meat, egg yolks, and wheat. Its active form is pyridoxal phosphate, which is used in transamination reactions, which is when you move an amine group from one molecule to another, such as the liver enzymes ALT and AST. ALT, or alanine transaminase, is important in the alanine cycle by transferring an amino group from the alanine to alpha-ketoglutarate, which converts the alanine into pyruvate and the alpha-ketoglutarate into glutamate. Similarly, AST, or aspartate transaminase, transfers an amino group from aspartate to alpha-ketoglutarate, which creates oxaloacetate and glutamate. Since these enzymes are both in the liver, levels of both ALT and AST in serum will be elevated after liver injury or due to hepatitis. Vitamin B6 is required as a cofactor for glycogen phosphorylase, which is important for maintaining blood glucose by freeing glucose from glycogen. It's also required for cystathionine synthesis from homocysteine, which in turn is used to make cysteine. So without B6, you could become deficient in cysteine. And you also need it as a cofactor for delta-aminolevulinic acid synthase. Do you remember what that enzyme is used for? It's the rate-limiting step in heme synthesis, and makes delta-aminolevulinic acid from glycine and succinyl coenzyme A. As I mentioned before, B6 is also required for the synthesis of niacin from tryptophan. B6 is a cofactor for many of the reactions used to make neurotransmitters, including dopamine, norepinephrine and epinephrine, and GABA. The last role I'll cover for B6 is that it's used to convert histidine to histamine. Do you remember the two types of cells to make and use histamine? That would be mast cells and basophils, and this one's an example of a basophil. B6 deficiency can cause convulsions, hyperirritability, peripheral neuropathy, and sideroblastic anemia. So why sideroblastic anemia? Remember, B6 is required for heme synthesis. So if you can't make heme, then the iron just accumulates in the mitochondria, which is pathologic, and can be visualized as these blue spots in sideroblasts, or atypical nucleated erythroblasts, which are the precursors to red blood cells. So where would you find these cells? Only in the bone marrow. And why would you have peripheral neuropathy? That's because pyridoxine is needed to make the ceramide and myelin. So without it, peripheral nerves can become demyelinated. Some drugs like isoniazid, cyclosporine, and penicillamine can inhibit pyridoxine and cause some of these symptoms. Vitamin B7, more commonly called biotin, is a water-soluble vitamin found in nuts, and is a cofactor that carries carboxylate, which is used in lipid and carbohydrate metabolism reactions. There are three major reactions that utilize biotin, and they're shown as the green circles in this diagram. The first is the conversion of pyruvate to oxaloacetate by pyruvate carboxylase. That's this arrow here. This is both an anaplerotic reaction for the TCA cycle, which means that it replenishes oxaloacetate if it gets too low, and it's also important for gluconeogenesis, since that starts with oxaloacetate. That being the case, which organs do you think have the highest expression of pyruvate carboxylase? That would be the liver and the kidneys, since those are responsible for almost all the gluconeogenesis in the body. The second reaction is the conversion of acetyl coenzyme A to malonyl coenzyme A by the enzyme acetyl coenzyme A carboxylase, which as you can see here is important for fatty acid synthesis. And the third reaction is the conversion of propionyl coenzyme A to methylmalonyl coenzyme A using the enzyme propionyl coenzyme A carboxylase. And that's necessary for the catabolism of odd-chain fatty acids and branched-chain amino acids. Notice that all three of these enzymes have the word carboxylase in them. If you see carboxylase, think biotin. Also know that reactions involving biotin will add one carbon to the substrate, such as by going from 3 to 4 carbons here, or 2 to 3 carbons here. Deficiency in biotin is pretty rare, but it can be caused by antibiotics and raw egg ingestion, because egg whites contain the protein avidin, which avidly binds to biotin, preventing it from being absorbed in the intestine. Symptoms of biotin deficiency include dermatitis, alopecia, and enteritis. Vitamin B9, or folic acid, is found in fruits and leafy green vegetables and performs one-carbon transfer reactions in the form of tetrahydrofolate, or THF. Tetrahydrofolate is synthesized from dihydrofolate by the addition of hydrogen from NADPH, which is catalyzed by dihydrofolate reductase, or DHFR. As I talked about in the first biochem section, tetrahydrofolate is important in the synthesis of pyrimidines in DNA and RNA. It was used at the very end of our pyrimidine synthesis pathway to synthesize DTMP from DUMP. As was the case with B12, folate is also stored in the liver. This makes it more difficult for people with a normal diet to become deficient, but in fact this is the most common vitamin deficiency in the United States, since people don't typically eat enough green vegetables. Deficiency can also be caused by several drugs, such as phenytoin, sulfonamides, or methotrexate. Phenytoin prevents absorption of folate. Sulfonamides inhibit an enzyme called dihydroapatite synthetase, which synthesizes a precursor of folate, and methotrexate and trimethoprim both inhibit dihydrofolate reductase. The most important time to not be folate deficient is during pregnancy, since folate deficiency can cause neural tube defects. As I mentioned before, folate deficiency can cause macrocytic megaloblastic anemia. However, it can be distinguished from B12 deficiency because there are no neurologic symptoms. Vitamin B12, or cobalamin, is only made by bacteria. None of the plants or animals that we eat can make it on their own, but we can still get it from animal products since they get it from bacteria in their bodies. It has a very specific absorption mechanism. A protein called intrinsic factor, which is secreted by gastric parietal cells, binds to B12 in the duodenum after it's been released from our protein by pancreatic enzymes. This intrinsic factor B12 complex binds to receptors in the distal ileum, which then absorb it into the enterocyte. Here, it loses intrinsic factor and binds to transcobalamin 2, which transports B12 through the bloodstream to the liver, where it's stored. Okay, so now that we have vitamin B12 stored, what do we need it for? B12 is a cofactor for the enzyme methionine synthase, also known as homocysteine methyltransferase. This enzyme takes the methyl group from tetrahydrofolate and adds it to homocysteine, which together create methionine. Now methionine is important because of course you need it to make proteins, and also it can be converted into SAM, which is used to donate that methyl group to other molecules. B12 is also used to convert methylmalonyl coenzyme A into succinyl coenzyme A. So when do we do this? Well, this is how odd-chain fatty acids and branched-chain amino acids enter the TCA cycle, and it's also an important step in heme synthesis. Okay, so what are some ways that people can become deficient in B12? Deficiency can be caused by lack of intrinsic factor due to gastric bypass surgery or destruction of gastric parietal cells, which causes pernicious anemia, and this will prevent the absorption of B12. Also, malabsorption can be caused by celiac sprue, which causes inflammation that prevents the enterocytes from absorbing B12. Another way is that the parasite Diphyllobothrium latum, which we'll talk about in the microbiology chapter, is a fish tapeworm that competes for B12 and lives in the small intestine. So patients with this parasite can become B12 deficient. And lastly, an absent or dysfunctional terminal ileum due to something like Crohn's disease or surgical removal will also cause B12 deficiency. Severe B12 deficiency can also cause folate deficiency, since methyl tetrahydrofolate can't be converted to tetrahydrofolate without B12. This folate deficiency can then prevent de novo pyrimidine synthesis, which is described at the beginning of this chapter. Prolonged B12 deficiency has neurological symptoms that include subacute combined degeneration of the posterior and lateral spinal columns due to a defect in myelin production. This manifests as ataxia and difficulty with proprioception and vibration sense. B12 and folate deficiency can both cause macrocytic megaloblastic anemia, which results in red blood cell mean cell volume greater than 110, and hypersegmented neutrophils, like the ones you can see in this image. Okay, so if we have a patient who is B12 deficient, how can we tell what's causing it? The Schilling test can be used to determine whether a patient's B12 deficiency is due to malabsorption, pernicious anemia, or dietary deficiency. In the first part of this test, patients are given radio-labeled B12 orally, which I'm showing as this green-bordered B12 here, and also an intramuscular injection of unlabeled B12, which is this one here. The unlabeled intramuscular B12 saturates the transcobalamin receptors in the liver so that any labeled B12 that is absorbed will be excreted in the urine. A normal test is greater than 5% excretion in the urine within 24 hours, and an abnormal test is less than 5% excretion. So what could cause a test to be abnormal? Well, a normal test could indicate that the patient's B12 deficiency is due to insufficient B12 in their diet, since they're able to absorb it normally, whereas an abnormal test indicates a problem with absorption. So if you're not excreting it in your urine, that means that it went straight out the digestive tract in your feces, since you never absorbed it in the first place. So if less than 5% of labeled B12 is found in the urine, we know the patient wasn't absorbing it. So how do we now figure out why the patient isn't absorbing B12? Well, to determine whether this is due to a problem in the intestine or lack of intrinsic factor from the gastric parietal cells, the test is repeated, but this time intrinsic factor is given orally with the B12. If this now produces a normal test, it means the patient has pernicious anemia, whereas if it's still abnormal, there's probably an absorption problem in the intestine. Alright, flash quiz time. So a deficiency in which vitamin causes macrocytic megaloblastic anemia, hypersegmented PMNs, and paresthesias? So this one would be vitamin B12. And for bonus points, if I didn't say paresthesias, what else could it be? That would be vitamin B9. So remember, deficiency of either B12 or B9 can give you macrocytic megaloblastic anemia and hypersegmented PMNs, but only B12 deficiency has neurological symptoms.
Hi everyone, this is our lecture on vitamin C. So let's get started. To get a clinical perspective, let's look at a quick flash case. Let's say a 72-year-old woman has a home visit by her primary care physician because her son noticed blood on her toothbrush and states she seems to be weaker. Her husband passed away 1 year ago and she has not had the motivation to leave her home or eat her favorite foods. She's primarily eating crackers and hot tea. Let's keep this in mind as we go through the lecture. Our learning objectives are to recognize the function of vitamin C and compare and contrast clinical manifestations of vitamin C deficiency and excess. Okay, so vitamin C, also known as ascorbic acid, is a well-known vitamin. You probably did not hear about it for the first time in medical school. What you'll commonly hear and see on commercials or other advertisements for foods, drinks, supplements, and other products containing vitamin C is that it functions as an antioxidant. What's an antioxidant again? It is anti or against oxidative damage. So it protects red blood cells and membranes from free radical damage. Can you recall what other vitamins are commonly referred to as antioxidants as well? If you're thinking of vitamin A and vitamin E, then that's great. Vitamin C is found in many fruits and vegetables, like the oranges and limes here. Vitamin C also facilitates iron absorption by reducing it to the Fe2+ or ferrous state. You can remember this by pronouncing ascorbic acid as absorbic acid instead. But who cares about iron, right? Well, remember, in our red blood cells, we have hemoglobin, which is made up of heme and globin. The heme is made up of iron and protoporphyrin. Curious as to what kind of iron? Of course you are. Iron in our hemoglobin is normally in a reduced state, or Fe2+. I like to remember it as reduced to just 2, or just the 2 of us, since Fe2+ is the ferrous state. Now, oxidized hemoglobin will have iron in the Fe3+ or ferric state, and this does not bind oxygen as readily as Fe2+. Instead, it has a higher affinity for cyanide, which could lead to tissue hypoxia from decreased oxygen saturation and decreased oxygen content. Can you think of a condition that can present with cyanosis and doesn't improve with supplemental oxygen? If you're thinking of methemoglobinemia, that's great. This is why vitamin C can serve as ancillary treatment for methemoglobinemia. It reduces Fe3+ to Fe2+. For more on this, check out the lectures on hemoglobin and methemoglobin. All right, that was a lot, but there's more. Vitamin C also is necessary for hydroxylation of proline and lysine in collagen synthesis. In this image, we can quickly see the overview of collagen synthesis and how step 2, the hydroxylation of proline and lysine residues, requires vitamin C. Okay, what else do we need vitamin C for? It also plays a role in catecholamine synthesis, as it's necessary for dopamine beta hydroxylase, which, as you can see in this red box, converts dopamine to norepinephrine. Now that we've reviewed some of the functions of vitamin C, let's talk about what a deficiency could do. Remember, we get our vitamin C from fruits and vegetables. So similar to our flash case, a deficiency could be precipitated by someone strictly on something known as a tea and toast diet, which may not necessarily be tea or toast, but could be water or crackers, which is common in the elderly who don't get up and go as much and primarily stay at home. In most parts of the world, water is readily available and can be warmed to make tea, and crackers or toast are easy to eat and easy to store. So the condition that can arise due to vitamin C deficiency is called scurvy, with a number of characteristic clinical findings including swollen gums like we can see in this picture, easy bruising, petechiae, hemarthrosis, anemia, poor wound healing, perifollicular and subperiosteal hemorrhages, and corkscrew hair. A mnemonic that may help you remember both function and disease is vitamin C deficiency causes scurvy due to a collagen hydroxylation defect. Additionally, vitamin C deficiency results in a weakened immune response. Well, now what about vitamin C excess? Some of the symptoms from vitamin C excess include nausea, vomiting, diarrhea, fatigue, and kidney stone formation, specifically calcium oxalate nephrolithiasis. Additionally, excess vitamin C can increase iron toxicity in predisposed individuals by increasing dietary iron absorption. Well, what individuals would be predisposed? Well, those who have conditions with excess iron already. So this can worsen hemochromatosis or transfusion-related iron overload. Great, let's do a quick flash quiz. Can you name 4 functions of vitamin C? Yes, 4 of the functions of vitamin C include acting as an antioxidant, facilitating iron absorption, and being necessary for both collagen and catecholamine synthesis. Okay, let's get back to this case. Well, sounds like this woman with her tea and toast diet, tea and crackers diet, has symptoms of vitamin C deficiency. There's blood on her toothbrush, which could be from swollen gums and scurvy. We don't know specifically what her son means by weaker, so we'd have to ask more questions, but it could be because she's anemic or has a weakened immune response due to vitamin C deficiency. Well, we've made it to the end. What's the bottom line? Vitamin C functions as an antioxidant, facilitates iron absorption, and is necessary for collagen and catecholamine synthesis. Vitamin C deficiency can lead to scurvy and a weakened immune response. And vitamin C excess can cause nausea, vomiting, diarrhea, fatigue, nephrolithiasis, and increased iron toxicity. That's all I have for you here. Please give this video a thumbs up if you liked it, and it'll give you the opportunity to submit a comment if you have any feedback or questions. Thanks for joining me. Study hard.
Vitamin D is a fat-soluble vitamin that comes in several different forms from several different sources. The D2 form is known as ergocalciferol, and you get it by eating plants and mushrooms, whereas the D3 form, cholecalciferol, is in fortified milk and also produced in sun-exposed skin. By the way, the vast majority of D3 that the average person gets is from sun-exposed skin, not from dietary intake. So how is D3 made from sun-exposed skin? It's actually a derivative of cholesterol. Cholesterol is converted to 7-dehydrocholesterol, which in the presence of UV radiation can be converted into D3. As for D2, even though we don't make it using sunlight, when it's made in other organisms, it also requires sunlight to be made. Do you know what it's made from? This kind of blew my mind when I first learned about it, but it's made from ergosterol, which should sound familiar because that's the thing found in cell membranes of fungi, which we target with some antifungal drugs. Everything's connected in the world of biochemistry. So anyway, D3 is the more important version. In the liver, it can be converted to its storage form by an enzyme that's only produced in the liver, called vitamin D25 hydroxylase. As its name suggests, this enzyme adds a hydroxyl group to the 25 carbon on this molecule, which is this one up here. The 25OH form of vitamin D doesn't do much, so to activate it we first have to send it to the kidney. And remember, since this is fat-soluble, it has to use a carrier protein to get to the kidney, which in this case is called vitamin D binding protein, which should be easy enough to remember. In the kidney, an enzyme called 25-hydroxyvitamin D3-1-alpha hydroxylase adds a hydroxyl group to the 1-carbon position, which is this one down here. Now we have the active form, which is 1,25-OH2 vitamin D3, also called calcitriol. So now that we have active calcitriol, what does it do? Vitamin D plays a role in bone metabolism by regulating calcium homeostasis. It maintains plasma calcium levels by increasing intestinal absorption of calcium and also of phosphate. It also reduces calcium excretion from the distal tubules in the kidney and can cause bone resorption to mobilize mineralized calcium. This will be discussed in more depth in the endocrine section. So vitamin D deficiency can cause a disease known as rickets in children, which manifests as soft bones that bend under the weight of the body, which you can see here. There's also a genetic disease that I mentioned in the genetics section called hypophosphatemic rickets, in which the vitamin D receptor is mutated. Do you remember the transmission pattern of this disease? It's actually one of the few X-linked dominant diseases. In adults, vitamin D deficiency can decrease bone density, but they won't bend since they're already fully developed, and this is known as osteomalacia. The bones will break more easily, though. Since vitamin D helps maintain sufficiently high levels of serum calcium, its deficiency can cause hypocalcemia, which affects physiology in a few ways. Do you remember what those are? One of the main symptoms is tetany, and this happens because having low calcium in serum allows sodium to enter cells, causing depolarization and therefore spontaneous muscle contraction. Hypocalcemia can also cause arrhythmias and seizures. Since D3 is formed in sun-exposed skin, deficiency occurs more commonly in dark-skinned patients. Babies whose diet consists mostly or entirely of breast milk and have minimal sun exposure should receive vitamin D supplementation. Excess vitamin D can cause hypercalcemia, which in turn results in hypercalciuria, since the body tries to get rid of the excess calcium by excreting it into the urine. In addition to excessive dietary intake, hypercalcemia can also be caused by sarcoidosis, in which vitamin D is activated by epithelioid macrophages. So a patient presents with tetany. Which vitamin deficiency could cause this, and by what mechanism? So tetany can be a symptom of a pretty extreme vitamin D deficiency, and the reason is that the patient would have hypocalcemia, which causes tetany. Vitamin E, also called tocopherol, is a fat-soluble antioxidant vitamin found in sunflower oil, corn oil, soybeans, meats, fruits, and vegetables. So this is an antioxidant, so I'll ask you, what cells in the body are really susceptible to oxidative stress? That would be erythrocytes. So vitamin E protects erythrocytes from free radical damage, so its deficiency can lead to increased fragility of erythrocytes, which in turn can cause hemolytic anemia. You might also see acanthocytes, which are these spiky red blood cells, for the same reason. Other signs of vitamin E deficiency include muscle weakness and posterior column and spinocerebellar tract demyelination. Also, a great excess of vitamin E can interfere with vitamin K metabolism. So this will have an anticoagulant effect and can be used to boost the effects of warfarin. So vitamin K is a fat-soluble vitamin that is mostly acquired from intestinal flora, but also found in some vegetables and animal sources. It's used to produce the clotting factors 2, 7, 9, and 10 in protein CNS. So where are these produced? That would be in the liver. So vitamin K is used here for a step called gamma carboxylation of glutamic acid residues on these proteins. This mechanism is discussed in more detail in the HemOnc chapter, but for now, keep in mind that it involves oxidation and reduction of vitamin K, and the enzyme epoxide reductase converts vitamin K from its oxidized to reduced form. The drug warfarin inhibits epoxide reductase, thus inhibiting the function of vitamin K, which in turn prevents the gamma carboxylation required to reduce clotting factors. You should keep an eye out for vitamin K deficiency in neonates since they have sterile intestines, or in anyone who's been taking a lot of antibiotics, since the primary source of vitamin K, again, is intestinal flora. People who are deficient in vitamin K can't produce enough clotting factors and are at risk for hemorrhage. Labs will show increased PT and PTT, but a normal bleeding time, since platelets still function normally. To prevent this, neonates are given intramuscular injections of vitamin K at birth. Zinc is a physiologic ion that's essential for the function of over 100 different enzymes, and it also helps proteins such as zinc-fingered transcription factors achieve the structure they need to function properly. Here's an image of part of a zinc-fingered transcription factor in which you can see the protein in blue and the zinc ion in green. Without zinc, the protein can't fold properly. Deficiency in zinc can prevent a lot of proteins from working properly and therefore causes a lot of different types of symptoms. Some of the main examples are delayed wound healing, hypogonadism, decreased axillary, facial, or pubic hair, dysgeusia, which means distortion of taste, and anosmia. It can also predispose patients to alcoholic cirrhosis. Most of the nutrition section is about things that are required for specific biochemical reactions which we can't make ourselves, and therefore have to consume in our diet, like vitamins and minerals. But really the most important thing that we eat is calories, since we can think of calories as basically a precursor to ATP, which is required for almost everything that goes on in a cell. Most of you will probably spend a lot more time dealing with patients who consume too many calories, but in many parts of the world, including some parts of the United States, insufficient calories is a much more serious problem. Treating malnutrition often comes down to either psychiatric care for eating disorders or social work for helping people get access to food they can't afford. But in the biochemistry chapter, let's just talk about the effect that malnutrition has on your body. For the step 1, you'll have to think about malnutrition in two different categories, which are called kwashiorkor and marasmus. The most common way that you'll be tested on this topic is either you'll have to identify which of the two categories your patient falls into, or you'll be given some signs and symptoms, which should clue you into one of these categories, and then you'll be asked which other feature you'd expect to see in that category. Alright, so what's the difference between kwashiorkor and marasmus? Well, marasmus is a bit more simple, so let's start there. This is your straightforward malnutrition. Usually, it's a child, and the problem is that they're not getting enough to eat. They're eating some vegetables, some proteins, some carbs, but there's not very much of any of them. These kids will be stick thin, with very little muscle or subcutaneous fat. No surprises here. Marasmus is exactly what you'd expect from someone who isn't getting enough calories. So what's different in kwashiorkor? Well, the key defining characteristic of kwashiorkor, the most important thing to know about malnutrition on the step 1, is that kwashiorkor is malnutrition with edema. One more time in case you weren't paying attention. What's the defining characteristic of kwashiorkor, which distinguishes it from marasmus? Edema. This will be most obvious at the abdomen, and classically, you'll see a child with a large swollen belly who's stick thin almost everywhere else. There's a few other features of kwashiorkor you have to know, including skin lesions such as hyperpigmentation or hyperkeratosis, which is thickening of the keratin layer in the skin, and a fatty liver, and you don't see these in marasmus. So just remember, all the weird stuff is in kwashiorkor. Alright, now for the hard part. What's different about the diet between someone with marasmus and someone with kwashiorkor, and why does one type of diet result in edema and the other doesn't? The thinking on this has actually changed quite a bit in recent years, and unfortunately the step 1 doesn't always get updated very quickly, so I'm going to teach you the right answer and also the wrong answer just in case. So historically it was thought that kwashiorkor was a state of specifically protein malnutrition, and the idea was that proteins such as albumin maintain the oncotic pressure of the vasculature, without which fluid can leak into the surrounding tissue causing edema. It turns out this isn't really true, since more recent studies have shown that malnourished people with adequate protein sometimes have edema anyway, and malnourished people with no protein sometimes don't have edema. Now, the step 1 might still believe this is true. So if you get a question that asks what is deficient in a malnourished patient with a swollen belly, and your choices are carbs, fat, protein, or calories, I would still put protein as the answer, and the mechanism of decreased oncotic pressure is important to think about as well. So if that's not the connection, then why do some malnourished people have edema? Another theory that has a lot of strong evidence now is that it has to do with insufficient intake of antioxidants, or with sulfur or cysteine, since these are important for glutathione reductase antioxidant pathway. Here you can see the structure of cysteine, and notice that this is an amino acid with sulfur in it. So deficiency either in cysteine or in sulfur in general could prevent the glutathione antioxidant pathway from working, which might contribute to the edema. Now again, that said, there are still some cases of malnourished patients without edema, which by definition is marasmus, who have insufficient antioxidant intake and don't develop edema anyway. So this probably isn't the whole story either. In any case, you should be familiar with the protein theory and the antioxidant theory, since either one might show up on your test, and also know that if you see edema, it may come with skin lesions or fatty liver.
Hey guys, we're going to be going over ethanol metabolism. So this is something that most of you might do after your Step 1 exam, but you can feel better about it if you know how it works beforehand. The reaction for the metabolism of ethanol is shown here. Ethanol is first oxidized to acetaldehyde by alcohol dehydrogenase, and this takes place in the cytosol. Next, acetaldehyde is further oxidized to acetate by acetaldehyde dehydrogenase. Notice that this second step occurs in the mitochondria and not in the cytosol. This is a small yet important detail that might show up on your test. NAD is utilized in both reactions as an oxidizing agent, and it is a limiting factor in this reaction. Alcohol dehydrogenase operates via a zero-order kinetic, and this means the rate does not change based on the concentration of alcohol. Again, another minute detail, but it can easily be tested on. Several medications can be used to treat alcohol poisoning and to maintain abstinence in alcoholics. Fomepizole inhibits alcohol dehydrogenase, but it is not used in situations involving excess ethanol. Instead, it's used as an antidote for methanol or ethylene glycol poisoning. This is because alcohol dehydrogenase is also used to convert methanol to formic acid, which can cause visual disturbances in methanol poisoning, and it's also used to convert ethanol glycol into glycolate and oxalate, and this can cause renal damage and ethanol glycol poisoning. Acetaldehyde is responsible for the symptoms of a hangover after excessive alcohol consumption. Disulfiram, or antabuse, is a drug that inhibits acetaldehyde dehydrogenase. This is actually a bad thing physiologically because it causes a buildup of acetaldehyde and therefore causes more severe hangover symptoms. Therefore, this drug is used to condition patients to abstain from alcohol in the future. The idea is, it's easier for a patient to make the decision when he gets up in the morning that he shouldn't drink that day and just take a pill, instead of having to make that decision later on when he's watching a football game, with his friends, or out at a party. However, patients can easily decide not to take the medication as well, which is a problem with this drug. A third alcohol abuse drug, which we'll discuss more in the psychiatry chapter, is naltrexone, and this is an opioid receptor antagonist. Therefore, it's centrally acting and is used for alcoholism. So why is alcoholism or chronic alcohol use bad for you? It isn't just frowned upon in excess. Alcoholism results in genuine health consequences by disrupting our normal glucose metabolism. Overall, the metabolism of ethanol results in an increased ratio of NADH to NAD+. Remember when we went over the reaction in the previous slide? NAD+ is converted to NADH, so after drinking a lot of alcohol, our body now has a whole lot of NADH at its disposal. The ratio of NAD to NADH is an important thing in cells. The metabolic reactions that use either one or the other will now be forced to go in a specific direction. Here's a picture of all the reactions we'll go over. The two main reactions are the interconversion of pyruvate to lactate and from malate to oxaloacetate. When the balance is shifted such that there is a lot more NADH than NAD, pyruvate will be converted to lactate to consume some of this excess NADH. And likewise, oxaloacetate will be converted back into malate. So basically, we're depleting the cell of pyruvate and oxaloacetate. How is this going to affect metabolism? Well, since oxaloacetate and pyruvate are the starting substrates for gluconeogenesis, and having excess NADH directs them away from gluconeogenesis, alcohol intake has an end result of preventing gluconeogenesis. This is the cause of hypoglycemia seen in chronic alcoholics. Additionally, the conversion of pyruvate to lactate results in lactic acidosis, and is a reason why ethanol and alcohol poisoning results in an acid-base disorder of anion gap metabolic acidosis. An increased NADH to NAD ratio also disfavors the TCA cycle. Acetyl-CoA, a major player in the TCA cycle, is then diverted away from the Krebs cycle, and this results in two things. One is ketoacidosis, as acetyl-CoA can be converted to ketogenesis. Two is the production of fatty acid, since acetyl-CoA can also be converted to lipogenesis. The fatty acids can combine with glycerol, which is formed from DHAP, to form triglycerides, and this causes hepatic steatosis, or a fatty liver. You can recognize this on a liver section by all these big white circles, which are big lipid droplets, which you can see here. What else can you see on histology? Mallory bodies, which the black arrow is pointing to. Mallory bodies are made of keratin and are common in alcoholic hepatitis and cirrhosis, but can you think of any other diseases in which you might see them? Some examples are Wilson's disease, primary biliary cirrhosis, and hepatocellular carcinoma. Thanks for watching. If you enjoyed the video, don't forget to give a thumbs up.